Imagine a patient sitting on your examination table. They are exhausted, restless, and battling a chronic complaint that just won't lift. Before you write a prescription, you have to answer a foundational question. Are you targeting a disease label, trying to suppress a single frustrating symptom, or looking to match the patient's entire health picture? Over 200 years ago, homeopathy's founder, Samuel Hahnemann, created a strict taxonomy to answer this question in the Organon of medicine. Hahnemann argued that a medical intervention should not be defined merely by its chemical mechanism. Instead, it must be evaluated by the relationship between the symptoms the medicine produces and the disease the patient already expresses. Based on this relationship, he categorized treatments into 4 primary pathways: allopathy, homeopathy, antipathy, and isopathy. This conceptual map visually separates those 4 pathways. Each branch represents a completely different logic to interact with the human body. Navigating these quadrants is essential to accurately predict whether treatment offers temporary relief or initiates a permanent cure. If you misclassify the logic behind your treatment, you lose the ability to anticipate its long-term clinical consequences. To evaluate real-world clinical cases, we can map Hahnemann's taxonomy onto a prescribing logic decision tree. Let's test it with a case. A 29-year-old software engineer presents with severe allergic rhinitis. She has an excoriating nasal discharge, high anxiety, chilliness, and she is managing it by taking a daily over-the-counter antihistamine. We ask our first logical question: does this daily antihistamine match her total characteristic symptom picture, including her mental state and thermal sensitivities? The answer is no, so we move down the tree and ask, does the medicine produce an effect directly opposite to her chief symptom? Yes, the antihistamine intentionally dries up her nasal secretions. Because it acts in direct opposition to the complaint, we classify this logic as antipathy, also known as enantiopathy. The immediate clinical result seems successful. The patient's nasal passages dry up, providing relief that lasts for 4 to 6 hours. Hahnemann defined this initial period of drug-induced relief as the medicine's primary action. But this graph illustrates a hidden danger outlined in aphorisms 57 through 60. Following that primary action comes the vital force's secondary reaction. The living organism automatically counteracts the drug's primary action. Once the antihistamine wears off, the body pushes back, causing the original nasal discharge to return with even greater intensity. For our patient, this means she now has to double her daily dose just to achieve the same baseline relief she started with. When applied to chronic conditions, antipathic palliation is not a cure. It weakens the body's vital resilience and traps the patient in a cycle of dependency. Let's return to the decision tree. What if we evaluate a treatment that does not directly oppose the chief symptom? We have to ask, what if the treatment targets a completely separate physiological pathway, an isolated tissue pathology, or a disease label, without attempting to match the patient's symptom totality? Hahnemann classified this relationship as allopathy. It relies entirely on prescribing medicinal symptoms that are dissimilar to the disease. Dissimilar treatments are highly effective at managing isolated structural emergencies, but Hahnemann argued they cannot dynamically resolve the original, holistic symptom picture, often leaving the internal disease untouched. We can pose another hypothetical for our rhinitis case. What if the practitioner prescribed the exact crude allergen, like unpotentized pollen, hoping to neutralize the disease? This logic is classified as isopathy. It relies strictly on a same-source relationship. It is important to correct a major professional misconception here. Isopathy, which relies on the physical identity of the disease's origin, is vastly different from classical homeopathy, which relies on the similarity of symptoms. Administering crude, same-source disease material can carry unpredictable safety risks. It is not synonymous with the principle of treating like with like. Both allopathy and isopathy fail the test of totality. One ignores the patient's symptom picture entirely in favor of a pathology, while the other confuses the physical source of the disease with the patient's unique expression of it. Let's reset the decision tree one last time to evaluate the final pathway, the specific logic Hahnemann designated for true chronic resolution. We apply this to the rhinitis case. The practitioner must find a medicine whose proven profile precisely matches the excoriating discharge, the chilliness, the thirst for warm water, and the specific anxiety. When this precise match is achieved, we classify it as homeopathy, a therapeutic relationship defined by true similarity. This visualization shows the concept in action. By introducing an artificial stimulus that is highly similar to the patient's totality, the medicine engages and displaces the natural disease dynamic. Because this approach matches the whole person rather than suppressing a single local symptom, it avoids destructive secondary rebound. The expected outcome of this similar therapeutic relationship is a gentle, complete, and permanent restoration of whole person health. True curative logic relies entirely on honoring the complete, individualized expression of the patient's vital force, rather than battling its loudest symptom. As this map illustrates, Hahnemann's taxonomy defines the strict boundaries of medical logic. Every intervention is either similar, opposite, dissimilar, or same source. Mastering this map is what prevents a practitioner from mistaking short-term suppression for long-term resolution. But applying this historically requires responsible academic framing. Sound clinical reasoning demands that we hold Hahnemann's historical philosophy in tension with modern safety protocols. While antipathy cannot cure a chronic disease, targeted palliation remains a humane and ethical necessity in cases of acute trauma or end-stage palliative care. Similarly, allopathic intervention is absolutely required for managing structural physical emergencies and providing critical pathological life support. A responsible practitioner knows exactly when to reach for different tools to manage different crises. But when the goal is the profound resolution of chronic dynamic disease, success relies on the foundational logic of similarity.